Hello, everybody. Welcome to the CRF conference. Thank you so much for, or webinar rather. Thank you so much for taking time out of your Friday. Happy Friday to everybody who's here in the queue. Just a couple housekeeping things. I want to introduce myself. I'm Beth Foss, and I'm the Director of Operations at the CRF. And today we have Katie Bales with us, and she comes from Emory University, and she's going to be sharing some information on eye health and wellness in terms of vitamins, supplements, and exercise that I know a lot of people ask about at every conference and almost at every chat too. It always seems to be something really popular. So we have quite a few people here today. Just a couple of housekeeping things again, folks. This is a webinar. I'm sure most of you have heard this a lot, but we're going to be using the chat feature. So if you want to go ahead and use that feature, ask your question at any time. And Katie and I have already chatted a little bit, and we'll be asking questions throughout her presentation. Again, I want to make sure that we say thank you so much to our sponsors, which would be Allergan and Biogen, for sponsoring these. Our list is getting quite extensive, everybody. So we have these webinars on our YouTube channel. So I would really encourage you on a rainy day or a boring evening, go check it out and see what else you might find interesting here at the CRF, which brings me to one more thing. Right now the CRF is doing a membership drive, and not trying to sound like, you know, NPR or anything, but it's time, if you can possibly, do some thinking and see if you could become a member of the CRF. And to those of you that already have, we certainly appreciate your sponsorship in that. It takes a lot of work, it takes a lot of money to fulfill our mission, which is finding a treatment for choroideremia. And we need just as many volunteers as we need dollars. So I'll end it there. I think I've hit everything. We're recording this video, and just want to say thank you so much to Katie. Thanks for joining us today. And I'll go ahead and turn off my audio and video and just take it over.
Okay, thank you so much, Beth, for that kind introduction. And let me get this all set up to go. Let me get my pointer. Okay, so thank you again so much for the coordinators for giving me this opportunity to share with you some of the research that's in the field, either what we currently know and studies I'm really, I can get behind, as well as our future studies here we're conducting at the VA, Emory, and Georgia Tech here in Atlanta. So, yeah, the title of my talk is Current and Future Neuroprotective Strategies for Retinal Diseases. And so I have a couple of disclosures. I have no financial disclosures in regards to any of the methods or studies I'm going to be talking about. I am by no means directly endorsing any of the methods I'm presenting. I am a vision scientist. I am not a clinician. And also, first and foremost, you must consult with your primary care physician before performing or engaging in any of the methods I'm going to be talking about. Okay, and like Beth said, please feel free to ask questions throughout. This is more of a conversation, not necessarily like a formal talk. So please feel free to ask throughout. Okay. Okay, so here at the Atlanta VA, obviously a lot of our studies are directed towards age-related eye diseases because our main demographic are veterans. And so because of our great healthcare here, as well as, you know, just the great healthcare and vaccinations, people are living longer lives, which is great. But this also means that the occurrence and the demographics of people who have either age-related macular degeneration, diabetic retinopathy, and glaucoma, there are going to be more and more people every year with those devastating blinding diseases. And so I know all of you are well aware of choroideremia, and although it's known as a rare disease, only affecting 1 in 50,000 people each year, I'm sure it does not feel like that to you, and I completely understand and I agree. But there is, regardless of which disease it is, there is an urgent need and demand to find effective treatments. Unfortunately, to date, there are no known cures or formal treatments of disease, although there are a lot of clinical trials going on that appear to be successful. And so although we are studying all of these diseases and working towards finding a cure, our most importantly, we want to know today, especially here at our studies at the Atlanta VA, Emory, and Georgia Tech, we want to know what we can do today to help you preserve your vision, and what methods and what treatments and supplements and vitamins do we support, and which ones are going to help you today, help preserve your vision. And so, although again, we mainly study these other diseases, a great silver lining to all of our studies is that there are similarities across these retinal diseases. So, there's photoreceptor degeneration, there's a loss of vision, and so there's a lot of similarities across these diseases, although they are different. And so throughout my talk, I'll be throwing around the word neuroprotection. I just quickly wanted to define what I mean by that. And so what I mean by neuroprotection is actually preserving the function of the retina. So how the retina works, we want to try to preserve that, as well as structure. And I'm going to talk about that in just a minute. But we want to know, and we're testing methods that are able to help slow down the progression of the disease. We want to know, what can we do today to help people such as yourselves. So some considerations we have when we're thinking about effective treatments for disease. So first and foremost, we want to talk about the safety of the method. Your safety is number one. We do not want to cause any harm or put anyone in danger with the methods or any sort of treatments we're creating. We also, those go hand in hand with the potential risk and side effects. So the risks associated with any of the methods we are conducting or any treatments we propose, the pros must outweigh the cons. There must be the benefits of the treatment, and the method must outweigh any side effects or any cons to the study. Also, the cost of treatment. We do not want to create methods as well as or any interventions that are not affordable, that everyday people can't afford. And that goes along with accessibility. We want you all to be able to access this type of care or treatment, and we want it to be simplistic, easy, and effective, as well as, we want to make sure with our studies, what are the outcome measurements? Are we successfully measuring if retinal or vision preservation is occurring properly? So we have to be very careful with how we're measuring vision progression or vision loss progression and such as that. So I'm going to go over some of how we do these outcome measurements. And so throughout my talk, I have a human eye, which is actually my eye, just to signify, these were studies conducted in patients and humans in a clinical trial, versus if you see this little mouse, that means that the studies that I'm presenting on are primarily those data are done in our animal studies. So before we hop into all of the supplements, as well as the methods such as exercise, I thought it'd be good for us to go over some very quick and dirty, simple, the biology of the eye. So light enters in through your eye through the cornea here. The light gets directed by the lens, which is kind of like a magnifying glass, if you will, which helps direct the light to the back of your eye where your neural retina resides. And so here's a cartoon of the neural retina. I'm not going to get in too much detail, even though I am a molecular biologist by trade. So seeing these images really gets me excited. But for today's talk, I'm going to not go there. But if you have questions, just let me know. But so this is the neural retina. So it's basically a network of cells that have very distinct and specialized roles. And so I like to think of them kind of as a network or a family. So if one part of your retina is misbehaving or not functioning properly, it will cause a domino effect. And so it will not only affect the function and how that one cell type is working, it will affect every single other cell type, and especially over time. So once one cell starts misbehaving, everybody else is affected as well. And so for choroidemia, the tissue or the layer that's most important for this disease is the choroid. So the choroid is responsible for blood flow and circulating nutrients and recycling of proteins. So what happens in choroideremia is it's the genetic disease is the dysfunction of Rab escort protein 1. Again, I'm more than happy to talk about this at a later talk, or if you want to, again, we'll talk about this another time, but just simplistically, it's when that one protein misbehaves. And so that is detrimental to the choroid. And so therefore the choroid is no longer functioning properly, which ultimately leads to dysfunction of the rest of the retina. And so what's very tricky and what makes retinal diseases so complicated to study is, unlike other cells in your body that replicate, like your skin cells, the photoreceptors and your neural retina, you're born with it, and that's all you get. There's no replicating of these cells. And so once they are dysfunctioning, they will eventually die. And there's no, at the moment, they will not reproduce or replicate. So once they're gone, they do not come back. And so that's one of the tricky things about studying these diseases, but we are finding ways to get around that. Some of the outcome measurements that we perform in the clinic or here in the lab is to look at, to assess whether or not a method is actually working to preserve retinal structures. We can take some pictures of the retina. So here, this is an example of an OCT, or optical coherence tomography. So it's a non-invasive way to take a picture essentially of your retina. So we can look at the cellular layers and get a good idea if this method or the supplement that we're giving is actually preserving those cells, and they're not dying or going away. And so so we can do that in patients, but in our animal models, we can actually take the retina from those animals and look at the structure of the histology of the retina here. So another way, also, I'm sure all of you, when you've gone to go get an eye exam, you're very familiar with the, read the line, the Snelling eye chart. Everyone's probably had this performed on them, or they've been engaged in it. And so this is a way for us to test over, throughout a clinical study, is your vision, your long distance vision or your close vision, if it's changing, or if it's staying the same or if it's changing. And so we can do that in our patients, but unfortunately our animals refuse to learn how to read. So we've had to come up with some other methods to be able to test their visual acuity. And so we do that with an OMR. And one of my favorite tests that we perform in the clinic is to look at retinal function. So seeing how well your retina is working. And so this is actually one of our participants in a clinical study I'll be talking about in my talk. And this is one of my bosses, Dr. Michelle Pardue. And so this is a way that we can test non-invasively, again, how well your retina is functioning. And so, when you go from a well-lit room to a very dark room, it takes a minute for your eyes to adjust. This is kind of a similar sort of test. And so once we do this test, we get these traces here. This is the electroretinography. So this is an ERG trace. So I'm not going to get into how the complications or how complicated this test is, but the takeaway message, what I want you to note, to pay attention with this waveform, is depending on if this trough right here, how deep this is, and how high this peak here of this line, that's what we're looking at to see, the distance between these two. And so with a big waveform like this means that this retina is responding to light efficiently and effectively. And so what's really cool about this squiggly line, if you will, is, this test had been around for years, but we can actually decipher this waveform tells us about different cell types in the retina. So how well those specific layers are working, which is really, really cool. So this dip right here relates to your photoreceptors. So your rods and your cones, the ones that actually detect the light. And then the peak of the wave lets us know about the bipolar cells. So these are a deeper layer of the neuroretina, as well as even these little squiggly lines that look insignificant, they're actually different cell types. So this test is very efficient, and it can give us a good idea of how well the retina is working. as well as we can do molecular assays. So this is just taking blood samples from either patients to look at different biomarkers that could be changing with the method or the treatment, or like such as exercise, for instance. You know, we can measure in the blood from patients as well as from animals in their retinas to see if things are changing. So we can see, okay, systematically, how is this treatment affecting, you know, not only if your eyes are benefiting, but what is it doing whole body? So those are some of the ways we can measure outcomes. And so the first supplement I want to talk about are over the counter. So talking about the AREDs and the AREDs 2 study. And so ARED stands for age-related eye disease study, and it's a formulation of high-dose antioxidants and zinc supplements. What is fascinating to me, which is so incredibly cool, is that this study actually began back in 2001, and it involved 11 different hospitals, 11 different centers, which means a lot of people participated in the study. So over 4,000 people, which is huge as far as a clinical trial goes. And so they were actually able to follow this group of 4,000 people for a decade and see, were these vitamins helping preserve their vision? And so how they did that, they looked at the pictures of the retina, like I showed you, as well as they did the visual acuity with the eye chart. And so measuring those, doing those periodically throughout the decade, they found that actually people showed a significant reduction in the risk of developing advanced AMD. So this study has 2 parts. So the first study used this formulation, AREDs, and then the second study that came out after looking at the data and figuring out, you know, what are some of the side effects and the potential risks with this formula, they developed this second formula. And so the formulas are different. And so it's very important to pay attention to those and seeing which one would be best for you. So although the AREDs supplements, they did reduce the progression from intermediate AMD to advanced. So these participants already had intermediate, so like a medium or a case of AMD. It helped not progress their disease into an advanced degree. So it helps slow down the progression. And so although these supplements do not prevent AMD onset, so the risk factors of developing AMD, there's a lot that goes into it. You know, there's genetics, lifestyle, smoking, a whole bunch of other things. We don't exactly know how the disease manifests, like how it starts. So we're still figuring that out, but we do know that these supplements do not prevent AMD onset. So a very important message, I think, with this study is that current and former smokers should take the AREDs 2 formula and avoid AREDs, the original formula here, because they found in their study that the beta carotene, which actually increased risk for lung cancer. And so that's something very serious in considering when you're looking at these supplements, definitely knowing that. And then here, this is just, you know, looking at the breakdown of the actual vitamins, but also they have these food sources that if you don't want to take a vitamin or you don't want to take a supplement, these are some foods that you can add into your diet that also provide the nutrient that is within the vitamin, within these supplements. Okay.
Hey, Katie, we have a question.
Mm-hmm.
Can I ask you now?
Yeah.
Okay, so somebody asked that if someone was going to be taking or chose to select AREDs 2 or AREDs to take on a regular basis, would that then replicate if you were already taking lutein or zeaxanthin? Should you stop lutein, zeaxanthin, and just take AREDs, or do both?
I think this is just my own personal opinion and based on what I know. Definitely consult with your doctor, but from what I've read in the field, I think too much is not good for anything. So I think taking one or the other is sufficient enough. I don't think double dipping is necessarily a good thing. So I think just sticking to one or the other is best.
We have one more question too.
Yeah.
Brent. Hey, Brent, as asking a question. So these AMD results, would they roughly equate with CHM? You think they're comparable?
I do think as far as the what patients with CHM are experiencing versus, what is found with AMD. So AMD is a very tricky disease. But as far as the leaky blood vessels and the vascular defects that occur in AMD I think are phenotypically similar to what's occurring in CHM. So I think people could benefit from, again, like how the overlapping of the retinal deficits that are occurring. I think that, we're seeing benefits in patients with AMD, although it has not been done in patients with CHM. I think that, at least these findings can be translated across diseases. And I don't think, at least from what I understand, the literature, there is no harm we don't know at the moment if there's what the risks are, but I do not, considering that over 4,000 people were in this study, I think it'd be okay to take these vitamins.
I think you can keep going. We're good.
Okay. Yeah, I was like, I don't know. Okay. Okay, I'll go. Okay, so the next over-the-counter supplement I'm going to talk about is TUDCA. And so TUDCA is actually a bile salt that naturally occurs in the body. And so studies back in the 1980s using TUDCA investigated liver cirrhosis. So it's actually been around for a while, but it's not FDA approved. So the synthetic bile acid has been shown to have neuroprotective properties for numerous neurodegenerative diseases such as Parkinson's and retinal degeneration. So studies conducted in our lab using multiple animal models of retinal disease such as retinitis pigmentosa, as well as an animal model of AMD. Doing TUDCA treatment, we've shown that it slows down photoreceptor degeneration. And so currently there is a clinical trial using UDCA, which is a TUDCA precursor. Your body converts UDCA to TUDCA as a treatment for retinal detachment. And so people who go into the hospital to have surgery, if they want to be in part of this phase 1 clinical trial, they can. And so they get a treatment, a single dose when they go in to get their surgery for the retinal detachment, and then they also do follow-up. I can provide the link to that study, but they're currently recruiting patients, and so they're actually using this as a method for potential to look at photoreceptor degeneration. And so the side effects, there are side effects associated with UDCA and TUDCA. People have reported moderate GI stress, as well as diarrhea with TUDCA treatment, and some users taking over 1,000 milligrams. And so here's some of the data from our animal studies that we've conducted here in Atlanta. And so using a model of retinal degeneration, so P18, that means that mouse was 18 days old. And so in this retinal degeneration, it's fast onset. So even at 18 days, we start start measuring retinal degeneration at the very beginning at 18 days. And so in the squiggly lines I talked at the beginning of this talk, so that, again, we did ERGs looking at the retinal function or how well the retina is working. And so the yellow line is a mouse that did not receive TUDCA treatment. They just received a saline injection. But the blue line is a mouse that received the TUDCA injection. And so you can see, again, like I said, how large this response is what we're looking at. And so there is a significant difference between a TUDCA-treated animal versus a vehicle-treated animal. So the retina is working a lot more efficiently, is working better in a TUDCA-treated animal versus a non-TUDCA-treated animal. And then we also looked at it 12 days later. So again, it's a progressive disease, and so we wanted to see if we were able to maintain retinal function over time after TUDCA treatment. And although the response is less, it's greater than that of the non-TUDCA treated animal 12 days later. So looking at retinal function, we also looked at some the retinal structure. So looking at the layers of the retina to see if they're going away or if cells are dying off. And so a method we use to look for that is called tunnel staining. And so wherever you see yellow in this image, that's showing you a cell that is dying. And so you can see here on the left, this is an animal that was not treated with TUDCA. So there's the appearance of more cells that are dying. And you can see that the thickness here on the left of this vehicle treated animal versus the TUDCA treated animal, this retina is a lot thicker than this one. So this means that these layers are going away, they're dying off. And so in a TUDCA treated animal, we see the less appearance of those yellow dots, which means that less cells are dying in this animal. And so, like I said, although TUDCA is in a clinical trial phase 1 right now, these animals were given injections and not taken as a supplement. So it's a little different, but future studies in our labs and others are further investigating TUDCA treatment with retinal degeneration. And so these results are promising, but we still have a lot of work to do moving forward in regards to TUDCA treatment with retinal degeneration. But these, again, this is an over-the-counter supplement you can take that's available. Okay, and so the next topic I want to talk about is we actually just completed a clinical trial here at the VA recruiting patients with diabetic retinopathy using levodopa. I have that misspelled, so excuse that. Levodopa in patients with diabetes but do not have the appearance of diabetic retinopathy. So part of a major part of our studies here is not only, neuroprotection, but finding ways to preserve your retinal function and structure before the appearance of degeneration even starts. So diabetic retinopathy occurs 10 to 15 years after patients have been diagnosed with diabetes. And so it takes that long for this disease, for the retinal vascular lesions and the degeneration to occur. So we want to find a method to help to help save the retina before this even starts. We want to help preserve and find methods that help slow down this process here. So currently diabetic screening detects late stage vascular changes. So that's, after 10 to 15 years after diagnosis, like I said, that's when diabetic retinopathy occurs. And so in our labs, in our animal studies in our animal models of diabetic retinopathy, as well as even in our diabetic patients, we saw that those squiggly lines that I talked about, those ERG traces, they showed a decrease in function before any of those vascular or those retinal deficits occurred in the clinic. So we could already test non-invasively that the retina was starting to not work well before the vascular lesions or any of that clinically diagnosis occurs. So we also found that in our diabetic animal models that the retina actually has decreased expression of dopamine. And so levodopa is actually prescribed with currently used as a prescription for patients with Parkinson's disease. And so we wanted to see very low doses and just a short clinical trial to see if the effects of levodopa could help patients with diabetes without the prevalence of diabetic retinopathy. And so dopamine is an essential neuromodulator or neurotransmitter in the brain, and that is naturally produced by the body. But in patients with diabetes, the expression is decreased. So we thought by giving supplementing dopamine prescribed by a doctor, we could see if that could change the retinal function or make the retina function better. And so sure enough, during our clinical trial using low doses of Seniment, we saw that over 2 weeks, with 2 weeks treatment of Seniment, we saw that the retina in diabetic patients was functioning as well as it was in our control patients or non-diabetic patients. And so the side effects we recorded in the study was frequent urination in one participant. And like I said, this was a very short-term study. Our future plans are to take this out longer because we know that patients with Parkinson's disease who take this drug, there are some severe side effects associated with it. And so we wanted to this study was also used to see what's the very minimal amount of dopamine we have to prescribe. And so we want to keep it at very minimum, very low. You know, we want to just give enough that will just help preserve the retinal function. That's in our future studies. And so now I'm going to switch it up and talk about exercise and our current studies we have going on here at the VA. I'm a clinical coordinator for our study with AMD and exercise, and looking at to see if aerobic exercise can help slow the progression of AMD. And so age-related macular degeneration is characterized by the deterioration of the retina and central vision loss, but there's not total blindness occurring. And so clinical trials as well as retrospective studies, so looking back at patient files and charts to see if they were active and how much exercise they received, they found that some people who were more active had their onset of AMD was later in life. And so this could be used as a potential treatment. And so what's really great about exercise and why I love it and why I'm studying it is because it's a therapeutic intervention that it does not need FDA approval. You can literally do it wherever you are, whenever you want. There's no special equipment, and it gives you a sense of self-empowerment. So it gives you a sense of taking control of your, in a time where, you know, when you feel like you don't have control over a progressive disease. So it helps give you a sense of self-empowerment. And so in our animal studies, we found that in our animal models of AMD, as well as retinal degeneration, that we found with exercising mice either on a treadmill or on a running wheel, giving them a running wheel to run freely whenever they want, we found that there's neuroprotection of the retina. So the retinal structure and function was saved associated with this increased levels of brain-derived neurotrophic factor. So that's a circulatory factor that was increased with exercise. We not only found it in the blood of these animals, but we also found it in the brain, increase of expression in the brain, as well as in the retina. So, you know, this is something in the body, you know, that's what's causing or providing the neuroprotection. And so, again, there's minimal side effects associated with exercise other than being sore or probably tired, but, you know, it gives you can control how intense you want it to be, which is really great. And so just showing some of the data from our study here at the VA recruiting patients for aerobic exercise. So here's just a rundown of the exercise protocol. So veterans we're using a stationary bike. And so they warm up for 5 minutes and then they sprint or climb for 1 minute. We actually, we have them wear a heart monitor, and we take every necessary precaution to make sure that they are fit to do physical exercise. But it's a series of sprints and climbs, and they work that up to an hour a day, 3 days a week. So that's just for our study, but other studies in the field have found, you know, just even 30 minutes a day of moderate exercise, such as walking, or maybe throwing in some strength training, is so beneficial, not only for your heart and your brain, but also for your eyes. And so after the first session, this graph is showing you after the first session of this veteran doing exercise who has age-related macular degeneration, the blue bars are showing you we saw an increase of BDNF expression throughout the exercise routine. So taking blood before he's even exercising, 15 minutes after exercise, 30 minutes after exercise, and then immediately after. And then, so looking at the expression levels of BDNF, and so we're seeing a gradual increase of BDNF here, which is very exciting for us. And so this is, you know, finding the best way to find effective treatments and methods for neuroprotection and preserving vision is, you know, to find out on a molecular level what's going on. And so this is giving us insight to formulate and develop the best methods as far as exercise. What is the best method for people with AMD or people with viremia? That could be part of our future plans. You know, we're trying to tailor these methods to best suit the type of degeneration that's occurring. And so
Katie, we had a quick question. Can I ask you, just jump in?
Yeah.
So regarding the intensity level of the exercise,
Yeah.
you said even walking is okay, but the question is the intensity of the exercise program like walking versus jogging versus running, is it better to get more rigorous, or is a moderate walk just as effective as a person who does triathlons?
Right, absolutely. Yeah. So again, it just goes back to your own personal, what your body can take. So we've actually done studies in our animal models here of AMD. And so we actually found low intensity to medium intensity exercise or running. So running them at a moderate or slower pace versus a high, very intense, rigorous pace. We found the low intensities to be most neuroprotective. So, just simply walking or, just getting moving for 30 minutes. Our future studies will look into the duration, but I mean, we ran those mice for an hour every day, and we found that the ones that were low intensity or medium intensity had the most neuroprotection occurring. So rigor is not always, you don't always have to go hard in the paint, exercising, just taking it easy and just doing what your body can do. And, just taking that into account. And, you don't have to be a triathlon, or you don't have to do, all those crazy savage races to receive the benefits of exercise. Just doing a minimal, just a walk in the park is sufficient enough. We found so far. So
That's really good news for those of us that aren't at
yeah,
that level.
yeah, we were actually really surprised. My other boss, Jeff Boatwright, he, as morbid as it may sound, he's like, we ran those mice to death, and it's like they didn't die, but the benefits, they did not. It was good. It's great news for us to know that, that we're not. It doesn't have to be super intense or super hard, or you don't have to lift, 10,000 pounds. Like, no, it's none of that. It's just, taking it easy, and just, you don't want to stress your body out either. So that's the whole point. Again, it's the pros and cons. It's that the balancing act. But just doing just some light exercise, your body will reap the benefits of that. So yeah.
We have a member, Todd, who's on the line with us today, who lives at a higher elevation. And he says that occasionally, after he is at that higher elevation, he can come down, and my sight seems to get worse for a while afterwards. Can exercise at altitude hurt our eyes because our retinas are more sensitive?
Yeah, that could be something that's probably related to your interocular pressure and the pressure that you're exercising at. Again, I think just being careful, and, I think as long as your body is used to the altitude changes, and I think that would be okay. But I think it's mostly just the pressure gradient, the pressure changes, because your eye is inflated, and there is a specific pressure gradient that occurs in there. So I know that studies looking at glaucoma and yoga, doing the inverted pose. How people remember when yoga, like I think a year or two ago, was really hot exercise to do. Actually doing the inverted, doing headstands is actually really terrible for your interocular pressure. So avoid doing those types of exercises for a prolonged amount of time. But I think just taking it easy, and you do have pressure in your eyes, so just being aware of that.
It's really interesting. I'm super glad that you mentioned that, because we do have a lot of people that use yoga as a stress monitor or way to get out stress. So that's great.
Yeah. So yoga is wonderful. Just be careful when don't be inverted for too long. I know everybody wants to do those headstands and, work on their yogi moves, but being inverted is not, for a prolonged amount of time, it's not good for your eyes. So
We have another question from Jason about exercise. Are variances in benefits from baritone intensities of exercise controlled against the starting fitness levels of participants? I'm glad he expanded. In other words, those who do intense exercise tends to be in better shape to bring with. So there are proportional benefits of low to moderate exercise for sedentary people is
right.
greater.
Mm-hmm. Yeah. So, yeah, that goes back to saying, you know, everyone is at a different level. Everyone's at a different starting level. And so, yeah, we're still figuring out, you know, what the best form of exercise is. So you can actually see from this graph here, you know, this participant, his first session of exercise, yeah, BDNF was rising gradually, but after his 35th session, so halfway through our exercise regimen, because our study is for 6 months, and so we take a baseline, a halfway point at 3 months, and then a final point at 6 months. And so looking at his BDNF expression after 3 months, it's not as in pink, it's not gradually rising just as it did when in the beginning. So, you know, that raises the question, is his body used to this type of exercise? You know, maybe he, you know, wasn't pushing himself as hard that day, or is it good to switch it up, doing cardio one day, strength training another, kind of tricking your body, if you will, because I know just as we get bored with methods and you know, different exercise regimens, maybe our bodies also acclimate and get used to those types of intensities. So switching up the different types of exercise may be good, but also just knowing your personal limits and not going beyond then to not create an unsafe environment for yourself as far as exercise goes. So I think that needs to be kept in mind as well. Did that answer his question?
I think so. We'll let him chat us up if that's not the case. But
Okay.
that's all the questions I have. You can keep going.
Okay, perfect. Yeah. So, just to summarize, what I've talked about today is that, you know, I've shown you that the AREDs and AREDs2 supplements reduce the progression by 25% in patients with intermediate AMD, but we do need to pay attention as far as which supplement is best for you. I've shown you that TUDCA treatment slowed the progression of retinal degeneration in our animal models, as well as in a phase 1 clinical trial currently. I've shown you that a clinical study prescribing levodopa to persons with diabetes pre-retinopathy has improved retinal function, and we're actually looking at performing a retrospective study now with patients prescribed levodopa and the occurrence of AMD, and so those data we're collecting currently just to see what those, you know, the role of levodopa treatment with AMD progression or the onset. And then I told you, I've shown you that aerobic exercise promotes biomarkers such as BDNF, which may play an important role in providing retinal neuroprotection. And so again, I just want to stress that you must consult with your primary care physician before you engage in any of these methods or implementing any new exercise routines. You want to make sure that you're being safe. And so with that, I'd like to thank and acknowledge my mentors, Michelle Pardue and Jeff Boatwright, as well as the numerous lab members who worked to get all of these data together, our Center for Visual and Neurocognitive Rehabilitation, the Emory Molecular Biology Core, and of course the CVNR Exercise Core, which is where we are performing all of our AMD and exercise clinical study, as well as our funding. And with that, I would like to leave, there's a list of current clinical trials for choroideremia. I've added the link here, as well as at-home exercises you can perform. At the VA, we have this wonderful program that's been around for over 15 years called GeroFit. It's actually designed for geriatric patients, but I think it's a great, it's great for people with low vision or vision issues or retinal degeneration. And so you can actually just watch simple YouTube videos. I've linked one here. They're actually kind of fun. We did one this past week on a webinar together. So it's just another resource for you all to use. So I'll take any other questions if you guys have any. And thank you so much for giving me this opportunity. I really appreciate it.
I'm going to leave that screen up. And just for folks to know that we are going to post this. I think you actually get, you might get a link to this when we send out our surveys, but we'll have this on our website as well. But we have a bunch of questions, so buckle up. The first one is from Ishmael. If I'm not a smoker, is the AREDs2 better than AREDs?
So the difference between the two is the beta carotene. And so I think if you're not a smoker, then I think you should definitely be doing the AREDs. I think they just did the second formulation because, again, patient safety and care is number one. And so they found that the extra beta carotene in the AREDs original formula was actually doing harm to patients. And so that's why the second formula came out. But I think taking AREDs, if you're not a smoker, if you were not a smoker previously, AREDs would be good for you. The original formula.
Great. Hey, just a personal shout out to Neil. Hey, I'm sorry, Neil, but your question didn't come through. So if you could please retype it, that would be great. Thank you. Here's another question. I'm a CHM patient and I have been using, I'm gonna get this. It's dorzolamide, HCI drops prescribed by my doctor. Please, could you mention if you have any study or can share any helpful information related to this medication?
Yeah, I don't know that one off the top of my head. So I would be more than happy to look that up and share any information with you, Beth, about that. I can do that for sure if you want to send me exactly how to spell it, because I didn't quite catch that. But yeah, I'd be more than happy to look up what information I can find about it. I do not know about that one off the top of my head, but yeah, I'd love to look that up.
Oh, that'd be perfect. And I'll get that to you, Yamal, for sure. I have your email address. I'll get that to you.
Yeah.
What are your thoughts on people? This is from Neil. What are your thoughts on people with a retinal disease and smoking in general?
I would say, based on what I've learned and what the field has said, that smoking is just, it wreaks havoc on your body and especially your vision. Your retina is just so it's constantly. I mean, all the tissues in your body are constantly working and working really hard. And so when you add something such as smoking to that mix, and you have a retinal degeneration, it really it's causing your cells in your body to work even harder to do their job. So, there's just so many risk factors and just negative side effects with smoking. And I know it's extremely hard to quit. It's terrible. And, I think just stopping is, if you can quit, that'd be great.
At the CRF conferences and in many discussions in our support groups, oftentimes people will say, what supplements should I be taking? And I think you shared some new ones, actually. I've been in the organization a long time and I haven't heard of these. Can you just speak to the point where a lot of people are taking lutein, zeaxanthin, bilberry, omega-3s? Are there general ones that you would also recommend if someone did not do the AREDs or the TUDCA?
Yeah, so I think so generally I think you can get a lot of those supplements just in a diet, eating leafy greens and getting your servings of vegetables or even adding fish. But if you're a picky eater or your kid doesn't like salmon, I think off the top of my head, I think a lot just having a well-balanced diet and eating clean is beneficial. But as far as those go, I think that what's out there in the literature, they do show to have overall systematically good benefits for your body as well as your vision. And so I think, we are still trying to develop new methods and new treatments and finding out, new supplements to add. And again, no studies have been conducted to see if AREDs and TUDCA can work together. I'm not endorsing that, but we still have a lot of work to do to see exactly tweaking supplements, dosages and all that stuff. So I think right now we're kind of building towards providing a lot more new information in regards to those. But
do you have any recommendations for the milligrams per day for TUDCA?
For TUDCA, so I believe the one I showed, let me fix this. Let me move my pointer. So let me see. So this one is 250 milligrams. I think starting off just to see how your body, because there are, the GI stress side effects and the diarrhea. That's something I would never wish upon someone to experience daily. Yeah, so just starting off at low dosages and seeing, I think the highest I would go is 500 milligrams, so I think that should be sufficient enough. So again, not more is not always better. Just being consistent is important, and also being safe too.
Here's a good question. Do you have any recommendations in terms of alcohol usage? Is wine, red wine, white wine, better than hard liquor? And if so, what is the amount?
Yeah, so I know a lot of some studies have come out saying, oh, or there's a lot on social media, like wine has so many antioxidants in it, and it's like so much better. This actual research behind those studies is not back. They do not back that up. So I think, minimal alcohol intake is best. 2 alcoholic drinks a day is for men, 1 alcoholic drink a day for women, but keeping that to a minimum is important. And I know a lot of people use it as, as a form of stress relief, or you socially drink, just not going over the top. And I think, alcohol is alcohol. It's all not great for you. So just trying to keep minimal intake of that is probably best. Because although, you think wine is made of grapes, but there are all those preservatives in it and sulfates, and it's just not good for your body. Your body is it's like poison basically for your body. So
good to know.
yeah.
Are there any prescription medicines that are known to cause ill effect on your eyes?
Right. Yeah. So I was researching that after we met, Beth, because I think that's a great question. I think a lot of the studies and what people are reading is, what's going to benefit, but it's important to also know what can harm your eyes. And so just looking over the supplements that are available, I did not find any studies to date that said that, anything that's being recommended that is going to cause any harm to your eyes at the moment. So, a lot of these studies, again, are thoroughly investigated as far as the AREDs, and TUDCA is still coming out. So, but I know as for AREDs, like over 4,000 people taking those vitamins for that study. That's a lot of people. And so I think if there were any negative side effects as far as vision goes, affecting vision, then they definitely would have described those. So at the moment, as far as supplements go, no. I think what things are being prescribed are okay, and I have not come across, or I wasn't able to find any vitamins necessarily that were negative, that would negatively affect your vision.
Excellent. Well, this is the final call. So anyone else that has any questions, please chat now. Otherwise, that was really good. That was very good. Thank you.
Yeah, you're welcome. Yeah, it's so nice to be able to talk to real people, if you will, because we're so used to just talking to other research scientists, and it's nice to be able to speak to the people that we're actually devoting our careers to, and looking for cures for you all. So this is a really great opportunity. So thank you.
Well, you were supposed to come, you and Marshall were supposed to come to, we're going to come to the conference.
Right.
And,
Yeah.
So hopefully you'll be able to meet us again soon, depending when we reschedule that. Hey, we do have one more question from Jason. Here we go. We have 2 more questions. Do the supplements described have any vasodilating effect? And if so, to what extent does that correlate with results?
Yeah. So
Jason's asking a lot of hard questions today. Good for
that's
you.
fine. They didn't report any vasodilation in these studies. I can definitely gonna back that up and look further into that, and I can give you that information, Beth. I'm not even sure if they looked into heart rate, and they didn't. I don't know if they even took those measurements. So that's a very important question. But as far as vitamin A or beta carotene and copper, I'll get back to you on that question because I don't think they described that in the ARED study. So I think that's a very important point. And so I'll get back to Jason on that one.
We have a couple people that are asking specifically about bilberry.
Okay.
Good? Not so good? What do you think? Or you can check on that too?
I'm gonna check on that too. Yeah.
That would be great.
Yeah.
Otherwise, my children would be having like 18 years of, I've been choking that down their throats for a long time.
Yeah, I'll get back to you on that one too.
That would
Yeah.
be good.
Yeah, I tried to speak to just the studies that we've had on our hands here at the VA, and then one that is, I mean, it's the colossal ARED study. So I can get back to you on all these other studies that you guys are also very.
That would be great. And we have one other question again. Is the same electroretinography and electroretinogram exams, is that the same thing?
Yes, those are the same thing. And so currently they're not implemented in the clinic at your either optometrist or sometimes your ophthalmologist might perform them. It's more of a, in the past, it's been a big clunky machine that takes a specialized technician to know how to use as well as read. And in the past, we've actually had to put like a wire electrode in the eye, which is super uncomfortable. You know, it's kind of scary if you're a patient. But now, as I've shown you in the talk, we actually have some sticker electrodes that go on the bottom of your eye. So it's a lot more comfortable. And so that is a handheld device. And so we have our lab and here at the Atlanta VA, we've actually come up with protocols with using that machine that we specifically designed. So hopefully that will be in a clinic near you within the next 5 years or so. So we're really, we've developed that test and then working with a company to be able to implement that in the clinics, because that is just a great way to diagnostic to see whether your retina is working well or not. That's easy and it's effective and efficient. So yeah.
Perfect. And for our audience today, I'll make sure that all of these notes that she's going to be sending us, I'll get it out to everybody, you know, within a reasonable amount of time. But I think that's it. We're going to end it here.
Okay, thank you.
Oh, no, we have one more. Do we have to? Okay, let's ask this. This will be the last one. How does the exercise benefit the eyes? Is it just through the BDNF or through other mechanisms as well, such as improving blood flow?
Right, exactly. So that's where my primary thrust of my studies go. So like I mentioned before, I'm a molecular biologist trained. And so my studies focus on, so yeah, the retina benefits from BDNF, but what cell types are exactly benefiting. And so I've shown in my animal models that your astrocytes are actually, the exercise with the effect of BDNF are changing the shape and the morphology of your cells in your retina, which is super cool. I've actually just submitted a grant on that work. And so I think that's really important, and it's and especially a great question about the blood flow. What's shocking is that there have been studies done looking at exercise and blood flow, but there are minimal studies conducted, especially clinical, with the effects of exercise and blood flow in a patient with retinal degeneration. So that's the other part of my grant, is look at that and the effects of blood flow with exercise. So BDNF is just one of the factors. There are a whole cornucopia of other ones that we're investigating, and so that's just like the tip of the iceberg. So we're really excited to move forward with those studies, and we'll let you know as it comes out, you know, what we find. So
maybe you'll have some more results then by the time, depending on how all this plays out with the COVID pandemic. If we meet again this year, next year, you'll have more data.
Yeah, definitely. Very excited.
Well, thank you so much. You were a pleasure, and you made some kind of more high-level things. You brought them down to our level, so we greatly thank you for that. And we want to thank you, our sponsors again, Allergan and Biogen. And we're just so excited we want to be able to give our members and folks with choroideremia and their family members that have joined us today just more things to put in our toolbox. And you certainly did that today for us.
Good. Very happy to do so. Thank you so much.
Thank you. Have a great weekend, everybody. And we'll be sending this out, and take care. Bye-bye.